Welcome, ladies and gentlemen, to the headquarters of Innovata Holdings. Thank you for joining us today. We are honored to have with us Dr. Mark Bishara, coming live from Ontario, Canada. Mark is the owner and founder of the Canadian Implant Dentistry Network, and we are very, very pleased to have him with us today. Mark, just off the bat, I'd just like to thank you very, very much. Me and Ioannis really appreciate everything that you've been doing with and believing in our innovation. And the ball is in your court.
So thanks for having me. This is, I would say, unusual time for everybody. And I think the best way to invest your time is by educating yourself and making the best of what's out there. So let's get going, and we'll have a Q&A session at the end as well. You can leave your questions in the chat box, and we'll go over that at the end.
Yeah, it's going to be good. Great. Okay, looking forward to it.
Okay, everybody can see me clearly? Okay. So we're going to touch on the topic of the emergence profile around implants. But before I jump into that, I wanted to touch base on the zero bone loss concept. Now, if you're on Instagram, you may have seen a lot of posts about this concept, especially on the book that's been released, and had the chance to maybe even read it. Why do I think this is so important? I think it plays a direct relationship with emergence profile management. I'm not going to go into a lot of depth into it, but I think it's important, especially when we're talking about tissue thickness and implant depth of placement, that it relates quite nicely to emergence profile and how we're going to handle that. So this is my family, and for anybody that understands the efforts that go into making these presentations and doing all these side projects, you need to have a supportive wife. So my wife's also a dentist who has her own practice, and these are my two kids, Jason and Emily. You may have already been a member of our network, which is based out of Toronto, which is the Canadian Implant Dentistry Network. So this is a project I started back in 2017, and it's grown over to 12,000 members online. And if you're not a member, come and join the Facebook group online for free to discuss cases and anything else you may have in mind related to implant dentistry. We also run study club sessions, hands-on educational courses in Toronto. We've also had them in Montreal just recently. So we've had speakers like Maurice Salama, we've had Dr. Frank Zastro, who's coming actually online at 2 o'clock today, Eastern Standard Time, on our forum to go over some of the concepts with the Curie block technique. And I encourage everybody who's in the area, and sometimes people come in from the United States, there are courses to check it out as well. So some pictures with past participants and speakers. Usually we have a good time and we go out to dinner after and have a really intimate discussion with colleagues and really just, get together and grow together. And that's the idea behind the Canadian Implant Dentistry Network. As well, Maurice Salama gave me a shout this week earlier and said, you want to put something together? And I said, why not? We have so much downtime. So this upcoming Tuesday, we decided to host an online implant symposium. And the neat thing is it's going to be a coordination between the Canadian Implant Dentistry Network and the Dental XP World Facebook group. So we have a number of great international speakers. Myself, Maurice, and his brother Henry will be moderating the session. And this should be a lot of fun on Tuesday. So this is at 11 a.m. Eastern. It's on either the Canadian Implant Dentistry Network Facebook group or the XP World Facebook group. It's going to be happening simultaneously. So let's jump to the zero bone loss concept. This was a picture that I had the chance to take with my colleague Thomas Linivicus back last year in Boston at the Quintessence meeting. And for me, I think when we look at crestal bone loss and the stability of implants around the crest, we need to understand what are some causes that are leading to this bone loss and methods of prevention. So we talk about implants with platform switching, and we talk about implants without platform switching, and you see all these kind of features and sometimes advertisement by companies, and you wonder what's gimmick and what's reality. So is platform switching the most effective way to achieve the task of preventing bone loss? Maybe, maybe not. So, I mean, in this case, we have a BioHorizon implant with no platform switching. It still has crestal bone stability around the head of the implant, and it works. So we need to look at a few factors which relate quite nicely to emergence profile. First, being the soft tissue thickness that's around the implant that we're planning to place. So if the vertical soft tissue thickness is 2 millimeters or less, you will have bone resorption in order to form a biological seal between the soft tissues and the implant and abutment restoration. So not every case is going to be treated the same way. So does platform switching maintain the vertical soft tissue thickness? I think we need to look at a few factors together. So when we have that biological width formation, and that happens at the time of placing your healing abutment, and is finished at around 8 weeks, we need to understand that once you have a certain amount of soft tissue that's too thin, that biological width is going to independently happen every single time to reestablish that thickness that's needed. So if you have a thin amount of tissue, you're going to need to place your implant perhaps deeper to compensate, or you're going to also need to increase the tissue thickness to compensate. So it has nothing to do with necessarily a platform switch feature. However, there are benefits to having implants with a platform switch feature, and we'll go over that next. So what are your options if you want to increase the soft tissue thickness? First, you can place your implants deeper or subcrestal. You have to keep in mind anatomy restrictions. Also, keep in mind if you place your implants quite subcrestal and then you don't have a platform switch feature or a stable conical connection, you will have bone resorption. So what happens is the prosthetics actually end up binding sometimes around the area, and some companies will provide bone profile drills, and they're meant in such cases such that the prosthetics fit into place. For me, I prefer an implant with a conical connection. There are advantages in doing so. It allows me to have less worry about movement, but there are also risks as well with a conical connection, such as fractures of implants, which can also happen. So it's just something to keep in mind, the advantages of, for example, an internal hex implant versus a conical connection implant. Another option is to flatten the ridge. So if you're able to reduce the ridge, then you're going to also increase the crown to root ratio. Keep in mind also, if you have teeth next door, by flattening the ridge, you may also end up compromising the integrity of those teeth. So you don't want to flatten the ridge in a sudden steep decline. You want to do it in a gradual slope in such a way that you don't have violation of the tooth next door. The gold standard being connective tissue grafts. If you're able to augment the tissue, you can go ahead and do that if your tissue is thin at the time of placement. If you're not comfortable with doing so, you can use other products like Alloderm, Matrix as an alternative. So this is something to keep in mind when you're going to place any case, especially in the posterior mandible. The tissue thickness tends to be thinner in cases where you've had tooth loss for an extended period of time, and you need to evaluate that and perhaps place your implant a little bit deeper to compensate. Another option is the tent pole technique, basically using the healing abutments. Some implant companies have cover screws as well that are a little bit taller, and that allows you to tent up the soft tissue in such a way that you have tissue growth over top. So that can be another option as well. This is a nice picture back from Dental XP meeting, I believe 2 years ago. Here we are in Miami, Florida, and we had a nice time on a cruise ship and in the evening session. And this is a case for my colleague Alberto Mazzelli, where he claims that 1.5 millimeters tissue height isn't enough. And I totally agree with him. So in this case by Dr. Mazzelli that he ended up placing implants into, we ended up actually placing our implants subcrestal. So when you have 2 millimeters subcrestal, and you have that soft tissue thickness of 1.5 millimeters, we're getting to that 3 to 4 millimeter range and ensuring that when we have our prosthetics going on, we don't have bone loss. So when we have a case and we wonder why we get bone loss once the healing abutment is placed or the prosthetics are placed, now we know why. So what is the correct abutment height selection? I typically will aim for 2.5 to 3.5 millimeter height abutments. The reason being, I want to avoid the situation in the middle here, which has the implant emergence of the crown right up against the bone profile. So if I have that pinching and killing off the blood supply right against the bone, what will happen? You'll get dieback of the bone in order to reestablish the biological width. So I prefer design more like on the right image, where we have a narrower abutment allowing thicker connective tissue and vitality around the area, and that allows for maintenance of the bone as a secondary effect. So this is a nice rule that I'd like to go by, being the margin of the restoration should be at least 1 millimeter above the crest of the bone and not more than 3 millimeters below the free gingival margin. So why did I bring up the zero bone loss concept? I mean, you can go and read this entire concept by yourself in the book, follow the literature, and also check out the videos that are posted online. But I think this plays directly into our placement depth when we're starting to implement cases, especially with the cervical concept. Because if we're not placing our implants to the appropriate depth, and we try and reestablish that emergence profile for our case, we're going to have issues. So it's important to understand that for every case, and depending on the zone of the mouth, whether it's an anterior or posterior tooth, that you need to place it at the appropriate depth with adequate thickness in order to sculpt or create that tissue next. So what is emergence profile? We need to look at it as a whole concept. It's how we turn an implant into a natural looking tooth. And ideally, you should customize this for every restoration you place in the mouth. And myself and Dr. Gregory Kurtzman, we have submitted a recent article to be published this year, directly discussing emergence profile management. And we touch base on a very important point. Is emergence profile a function of implant diameter, depth, or soft tissue, or all the above? So there's many reasons why we need to place a narrower implant. So for example, in the anterior zone, often we're going to 3.5, 4 millimeter diameter implants. And the reason being is we're already so close to that buccal plate and we know that it's going to resorb. So we try and stay very far away from the buccal plate, and we try and graft the gap and increase the area with soft tissue grafts. And if we rely on implant diameter only for emergence profile, it means that in the long term, we're going to have less bone around our implant. So in certain cases, it's actually better to go to a narrower implant and control the emergence profile by the tissue itself. So on the right here, for example, this is a molar case, but if you go from a 3.5 millimeter diameter implant all the way up to a 5 millimeter diameter implant, if you use a wider implant, that implant sure will be closer mesial distally to the emergence profile that you want. But keep in mind, buccolingually, often we're deficient. And by doing so, we're taking away bone in the long term. So I personally would prefer to have an extra millimeter of bone around my implant if it was in my mouth, rather than having an extra millimeter of titanium. So typically in the posterior aspect, I'm aiming for implants of between 4.5 to 5 millimeter diameter now. And that's more than adequate in terms of function and in order to handle stresses of the area. What are some factors for success? So we need to look at the thickness of the tissue around each implant. We need to look at the horizontal cross-section of the future crown, and also the position of the crown relative to the bone. So a case that's in the posterior mandible is going to be entirely different in terms of depth versus something like in the anterior zone where we need to place it a bit deeper. in order to hide, for example, the titanium gray show through of the tissue. And this is very challenging, especially as we get into the posterior zone. So in the anterior, maybe we get away with using a stock abutment because the stock abutment is circular and it maybe resembles a custom healing abutment, and we can maybe squeeze the tissue into place and have it control the tissue in such a way that we don't have issues. But on the posterior aspect, we have multi-rooted teeth. We're trying to take those multi-rooted teeth and convert them into something that is off a single implant. That can be a challenge. And especially here, you can see we have cross-section of teeth, and we have different teeth shapes like triangular, rhomboidal. And how do we get those shapes adequately replicated with something that is circular in nature, like an implant platform? Also, how deep can you place your implant? We have many connections. We have external hex, internal hex. You have implants that are conical. You have implants that are tissue level. So it's important to understand the guidelines from each manufacturer and to understand the limitations of each system. So I'm not here to tell you that the lesson from today only applies to a certain implant company. That's not the point of the discussion. The point is to understand that with each system and features that it comes with, you need to understand if you can place that implant deeper. So if you can place the implant deeper, it might have benefits. But also you need to be able to understand, in certain cases, some systems are not meant to be placed subcrestal. So you need to understand the features of each implant system and understand why you're using it. Why is this important? We need to avoid food traps, and we need to recreate papilla. We want to avoid what we call a tomato on a stick on our implant crown designs. So if I give a patient on the left a crown that's shaped like this, and the patient complains of issues, an implant like this is not placed adequately deep enough. The crown has a very stocky shape to it, and the technician is not going to be able to give you something that in any way resembles a natural tooth, and it's not his fault because you, as a surgeon, did not place the implant at the right level. So we want to ensure that we have something that is easily recreated by the technician, or if you're doing your own design in your office, that you can pass that information and you can also work together in conjunction and make sure that you don't have issues. So we're going to go over a lot of cases and expand on this concept next. A lot of the cases I'll show also deal with immediate molar implants. So some people ask me, how do you know where to place your implants for immediate molars? And a quick rule of thumb is that you should aim for the septum, because the septum in most cases, if you're planning to do an immediate molar placement, works out to be a great reference or landmark for your implant depth. By the time you get remodeling around the implant, your implants tend to be at the right level in terms of depth in order to recreate that emergence profile that you need. So where should you place your implant, and how wide of an implant should you place? I think this is a very good principle that I like to go by, and the rule is this. We try and place an implant as shallow as possible, but also as deep as necessary. So what does that mean? So if you have an implant in the posterior zone, you can place it as shallow as possible, and we don't have to worry as much about aesthetic issues, but it can be as deep as necessary. So if we transition to, for example, the anterior zone, we need to have an implant placed deep enough to deal with aesthetic issues, but also to deal with potential shine through of the titanium itself. So it's basically a balance between aesthetics and biologic principles. So this is a case which I didn't place, but was that came to my practice. And the patient came in initially, disappeared for 2-3 years, and the end result was I had to remove the implant. And you can see that the design of this implant was deficient in terms of a ridge lap design. So number one, the lab didn't understand the principles of the design of an implant crown. Secondly, the implant placement was too shallow. So this is the reason the lab ended up placing the crown with such a design. But the dentist didn't understand that there's something wrong in communicating back with the laboratory to say, hey, this design is not cleansable. So it's a twofold problem when we're having somebody who doesn't understand from the dentist's perspective, whether you're doing the surgery itself or you're doing the surgery and doing or having referrals sent back to your GP. And if that dentist doesn't understand what's wrong with it, you'll end up with issues. So in terms of aesthetic principles and biologic principles, the technician needs to understand this, but the dentist needs to understand this as well. Here's another case that we had in discussion on the online forum, and this is what a fellow colleague had returned back from the lab. So for me, when I see this, I shake my head. So either the implant was not placed deep enough, or the lab didn't understand what to design, or maybe we didn't give this lab enough information. So I mean, if a lab is smart or a technician's educated on this, maybe they can give you something that's in ideal form, and you can give it back to the doctor, and then you insert the crown, and you most of the time you tell the patient, I'm going to squeeze the crown down a bit and insert it into place, and you may feel a pinch, and then you wait a few minutes and you come back and you tighten again, and the tissue blanches, and you hope that everything settles into place. For me, I don't like this philosophy, because if I control everything up to the end point, my inserts are no longer than 5 to 10 minutes without local or any pain to the patient, because we've managed to control that profile ahead of time. So I'd like to understand here one thing, and for me, that the concept of using just an implant diameter to control the emergence profile, I think this is a misconception. So we see a lot of doctors discussing, well, I need to place an implant that's 6, 7, 8 millimeter in diameter in the posterior zone in order to control my emergence profile. Well, the emergence profile, it's not a function of just your implant diameter. So bone sets the tone, but tissue is the issue. A quote from Dr. David Garber, we need to keep in mind that we are also able to manipulate the tissue for using an implant that's a little bit narrower in such a way to also get an ideal result. And I'll show a lot of those cases next. So let's jump into the cervical portion. And for me, I kind of, ran or met into this concept by chance, just from discussions online. So I haven't even had the pleasure of meeting, Ioannis, myself in person, but from our chats online, when I saw this, the concept just made sense and clicked into place as to why I should be using this in my practice, and especially in the posterior zone. In molars, this is where I find it's most crucial, because stock healing abutments do not resemble at all what the cross section of teeth look like at the CEJ. So there are many ways to recreate that soft tissue emergence. So you can make your healing abutment chair side by adding composite to it. And I've seen some colleagues advocate for putting the flowable into the wound after an extraction is performed and curing that intraorally. I think this is not a good idea. It can create monomer release and can cause issues in terms of inflammation and healing issues. I think it's better to have everything done outside of the mouth. So you can either have a lab, for example, mill or print you custom healing abutments. But the truth of it is, a lot of people are not ready yet to jump into having something like a mill or printer or any of these factors yet in their office. So having the ability to make something chair side with flowable that you can adjust or add to is a very big advantage with this system. I'd like to just touch base on the dynamic compression technique. This is another technique to do this. Basically, you're over contouring your provisional and cutting back that provisional to allow the soft tissue to creep into place. Keep in mind with this concept that it does take a number of visits in order to get the soft tissue profile that you're aiming for. So why is emergence profile so important? For me, we're trying to make this easily cleansable for the patient and maintain home care as easy as possible. So the peri-implant seal, by definition, is to maintain homeostasis of the internal environment in responses to challenges from the external environment. So what are some challenges that we face from the external environment? So we have patients, home care can be inadequate. You have issues like plaque building up around the potential implant and leading to mucositis, peri-implant disease. And this plaque zone tends to be about 1 to 1.5 millimeters. And the biologic zone around our implants tends to be 2 to 3 millimeters. So if we can push that zone away, that plaque zone away from the implant heads, we're going to give the patient a chance in order to maintain and keep this clean at home easier. And we all know that teeth behave differently than implants. So if we have a case like this, for example, then a case like this will have a different outcome, whether it's with a stock healing abutment or it's a custom healing abutment. And we also know that teeth are much more resistant to invasion of plaque and bacteria versus implants. And that's because of the fiber orientation in implants relative to teeth. So do you have peri-implant complications? And if the answer is no, then you're not placing enough implants, or you have not been in practice as many years yet to see your own complications come around. So for me, I'm at the 10-year mark myself. I can still consider myself a rookie in the implant world. But as you see your cases come back, you want to ensure that you don't have these issues yourself. And in the literature, the complication rate can be quite high. And I can say that probably over 50% of our patients will have issues of peri-implant disease. In the past, we blamed it on certain things. We said, is it a certain implant brand? Is it errors from our end? Was the bone too thin? Is it surface coatings of certain implants that are now discontinued? And we didn't know what was causing it. But now I would say a lot of implant companies, in terms of what's provided on the surfaces, is quite similar in terms of what we understand about implants, and not using an implant that's too wide, respecting thickness of the buccal lingual plates and those kinds of features. We have quite a good understanding of what we can control. But I think the area where we're lacking is the emergence profile around our implants, and in terms of communication with the laboratory on how to achieve that next. So reality can be harsh, and we want to avoid these situations. So for me, I think peri-implant disease has a strong correlation with emergence profile, because if the patient is unable to keep the area clean at home, you're going to have issues. And for me, whether you're doing this digitally or analog, the end result is still the same. And I'm going to go over a lot of these cases next, in which I perform things digitally in my office. I've been digitally scanning in practice for 8 years, starting off with the iTero. Now we have the Medit and also a Trios scanner in office. We also have a full digital lab in office in order to provide all sorts of implant aspects. I'm not saying you need to jump into setting up a full lab yourself, but it's important to understand these concepts. And whether you're just starting to get into potentially scanning and the digital world, you can leave a message here or join the forum, and I'll be happy to help you to understand how to get into the digital pathway. So let's get into some cases, whether you're doing this with an analog method or digital, it's the exact same concepts. It's important to understand that if you're doing this with an analog method, you'll want to also capture that emergence profile. So on the left here, we're showing an impression coping, which has had the emergence profile replicated internally with flowable so that it can be sent to the laboratory. However, if you do this digitally, you don't actually need to modify your scan body in order to capture that emergence profile. And I'll go over the cases and why I believe that's the case next.
Now you can keep track of everything better and save what inside. That's where
So this is a case of mine on an upper molar implant that I had placed and I was ready to restore. And this is done on the triage system. This is a scan body using a Neodent implant. We don't have to necessarily modify the scan body when we're doing emergence profile capturing digitally. The reason being is that if you're able to take off your custom healing abutment and within a few minutes, you'll have tissue collapse. But before the tissue collapses, if you're able to capture that scan of that data area right away, then place your scan body on and then do another scan. The software is able to merge that data together. And the nice thing is sometimes you have narrow areas, and when you have the scan body on, you're not able to capture the proximal contacts of the adjacent teeth. So by having the scan body off first, you're able to capture emergence profile and proximal contacts. Once you're done that, then you'll place your scan body on and the software merges it together. So it works quite easily without issue. And in terms of depth, the scanner can still scan quite deep into the area, even on an implant that's been placed deeper. And I'll show that next in some cases. So how can we manage the emergence profile? So the nice thing about this system is that it's set up in such a way that it's organized by different regions of the mouth. And it comes with what we call a cervical guide and a cervical mold. And this gives us the ability to create an emergence profile and custom healing abutment within a 7-minute time frame with our patient's chair side. So what happens is that you bring this magnetic handle with tabs that correspond to different areas of the mouth. And once you have measured these tabs intraorally using the magnetic handle, you will choose in the cervical mold the corresponding shape by the different zone of the mouth. Also, keep in mind that you see these tabs have a central placement and an off-angle placement hole. So in some cases, like if you place an implant in a premolar zone, sometimes you're placing your implant centrally and sometimes you're placing your implant lingually. The same thing goes in the anterior zone or in any area. So if you're doing an offset placement of your implant, you will simply switch out the silicone index of the cervical mold to accommodate for that. So it's quite intuitive. Okay, so you'll bring it into the mouth and measure the space. And when you're measuring the space, it's important to understand that it's better to go with a smaller profile than one that's too wide. So if you're debating between two sizes, it's better to go a little bit smaller because it's easier to also modify intraorally rather than having it bind against the adjacent tooth. Keep in mind also when you're placing your implant to line up the positioning of your implant flat side or dot on your carrier to the buccal. That way, when you go and make your healing abutment next, you have the orientation of your custom healing abutment fitting in the exact orientation, and it's not off angle by a little bit. Okay, so I prefer to use peak abutments when I'm creating these. You can see what your manufacturer offers in terms of temporary abutments. Okay, so then you'll bring your temporary abutment into the mold and fill it with flowable, cure it, and remove and polish it. The system as well comes with up to 36 different connections, although in most cases you're not going to need to use all 36 connections. If you have a practice that's dealing with a number of different implant systems, you have up to 36 different connections. As well, it also has the feature of crestal all the way to 3 millimeters subcrestal. So for myself, the implant system I'm placing right now is a Neodent GM. I'm placing my implants between 1 to 2 millimeters subcrestal. So my lab analog that's positioned in the system or in the mold is typically in the 1 millimeter subcrestal position. And why is that so important? When we're trying to create an emergence profile in implants that are placed subcrestal, we do not want the emergence profile under the bone to start with any flare. If you have a flare in that aspect, you'll get pinching against the bone and you'll get dieback of the bone. So it's important to maintain as narrow of a profile as possible and to start that emergence once you're above the bone. And the top picture here illustrates this perfectly. So you can see in areas where the implant placement is subcrestal, you want to have in the yellow section as narrow of an emergence profile as possible before you start your emergence contour. So has this ever happened to people? You place your implant and the design of the prosthetics of that system have issues with binding, and you go take an x-ray and you see your healing abutment was not sitting all the way. You have to go profile the bone and perhaps make your implant a little bit not as deep. So for me, the implant system features that I like include having healing abutments with what I call a tulip shaped design. And when that happens, it allows me to control the placement depth in order to place it subcrestal, but without having to worry about pinching. And like I mentioned, you can have these in a centered or off-centered position as well. And these are the silicone inserts. Most of the time you will be using the centered position insert, but it's nice to know that you have the feature of the off-center position in terms of placement in the central position or in a lingual position, like in a premolar or for example, anterior tooth. You also have the ability to duplicate it if you wish. So there's a slot here for you to duplicate it as well. So if you're doing things in an analog world, this is to duplicate your profile if you wish in order to replicate that emergence profile in your impression coping. For myself, I don't have to worry about this because I'm doing things digitally. And to be honest, I don't think I'll go back to the analog world, especially on single or up to 3-unit, 4-unit implant procedures. I find digital works quite well. It's only when we start to get into multi-implants and full arch cases that I still find it's better to take a full arch impression, because sometimes you will have issues in terms of scanning a full arch and ensuring that you have accuracy of fit. So some of these examples are from Dr. Ioannis. I'll touch on these briefly, then I'll jump into my cases that are done digitally. So here's an example of a case in which a custom healing abutment was made, and the profile is seen 2 weeks later. You can also have a dot placed on your temporary healing abutment that's made to ensure that it's placed to the correct orientation on the buccal when you're polishing it and doing any kind of trimming outside the mouth. So this case was done in a conventional analog world. Continuing with some further cases here. And I think everybody's able to achieve these kinds of consistent results if they understand the features of the system. Here's a case courtesy of a fellow periodontist who I introduced the system to here. This was one of his first cases that he had done. And this is the pictures he sent me. So this is somebody who's now going to send this case back to his referrals. He can also send back the custom impression coping to his referral. And look how much more information the laboratory has here. The lab is able to have no issues in terms of profile management of the area. Okay. Here's another case here. This was a referral case. The patient had implant placed elsewhere, and the implant that was placed elsewhere had issues in terms of seating. The patient also had a very limited opening. I told her that I have a digital scanner in my practice, and I think I can improve on the situation. So when she came in, the tie base had separated from the original implant crown, which I had to remove. So I said, you know, I think I can also improve on the soft tissue profile of the area if she, and I showed her some pictures. And some patients, they are quite educated if they're investing into implants. And once you show them why you're doing this and why this is a bit different than what they have in their mouth, they will go for it. So I ended up making a custom healing abutment. And this is at 3 weeks. I didn't do any kind of grafting of the area, simply by splitting the tissue, placing my custom healing abutment. Look how much extra keratinized tissue I was able to achieve here. And this is the digital scan. So look at the difference here. The ridge now, not the bone, of course, but the soft tissue thickness is incredibly different. And I think we'll be looking into this more and more digitally, especially before and after, how much tissue we can gain by using custom healing abutments. So for me, if I send something like this stock to the laboratory and I tell them to design an implant crown, I think you'll have issues of food trap. Also, the lab is guessing. They don't know, unless you communicate with an X-ray, the implant placement depth, where on the gingival mold your implant is. They can over contour your implant crown, under contour it. And I've seen that happen as well, because there's not enough information conveyed to the lab, especially on posterior zones of the mouth. Here's another case, upper molar that was fractured, endo-treated. So I told the patient that if we can, we'll do an immediate placement on the day of. So we ended up doing extraction atraumatically. You can see the sinus lining in the third picture. We did sinus elevation indirectly, used PRF to seal any potential perforations, and placement of a 4.3 by 11.5 Neodent CM. That's what I was using at the time. Grafting the area and closing it up. And look at the emergence profile here that we were able to achieve. So you don't have to necessarily go to creating the soft tissue emergence profile on the day of if you're worried about potential implant stability or patient compliance. You can let this heal over and come back at second stage and perform this. So there's nothing wrong with that. And that's the insert. Another case here in the upper jaw. Tooth is taken out. Implant placement. custom healing abutment, and then digitally scanning it, sending it to the lab. Here's another case here. Patient had another upper molar, so you can see a trend here. A lot of these are upper molars, endodontically treated. You can see that we've done a gutta-perca tracing to the fracture in the mesiobuccal root. We ended up taking out the tooth, placing an implant with indirect sinus lift, doing an ISQ check of the anterior implant stability, which was restored a little bit earlier, and then digitally scanning the case. This patient, you know, my inserts are very fast with these cases because we've controlled the emergence profile. This is an older case, one of my very first few cases with emergence, with the partial extraction therapy concept. So I had a broken tooth next to an adjacent implant. So for me, when I have adjacent implants, that's when I begin to worry, especially if the implant, one of them was already previously placed, and then the tooth next to it broke. If I perform complete extraction of that tooth, I worry about the bone peaks next to that implant and the potential soft tissue recession outcomes. So I performed partial extraction therapy at the time. What I would have designed differently is the crown. I'm not happy with the design. I didn't quite understand at the time enough about the concepts of keeping that abutment to be taller away from the implant head, because you don't want that to compress and cause pressure against the shield and potential loosening and infection. Luckily, we haven't had to deal with that, but I would design this case differently now. So I would use a taller abutment. I would also have less compression potential against the shield, and the patient, for now, she's left her molar. See when she comes back to have that restored. Here's another case with immediate anterior partial extraction. So we had an old external hex Brandemark implant placed over 20 years ago. Patient had external resorption on the adjacent central. We went ahead and performed partial extraction therapy on the tooth next to the implant. Placement of Neodent CM implant at the time. You can see this is a favorite x-ray of mine because it shows kind of the transition in terms of principles of what we're used to. So we have an external hex Brandemark implant that's placed quite deep, and then we have a platform switched implant with socket shield with a taller abutment. So it's basically an evolution that we see in the x-ray from what we see 20 years ago till now. So we immediately loaded the case out of occlusion. And when we returned 3 months later, we performed again digitally scanning of the case. So we have a scan body on the old external hex Brandemark implant. And you can see quite the depression here that's been occurring from complete extraction therapy around that old implant or potential accident that happened. So the nice thing is about this system is that you can also use it for making not just a temporary healing abutment, you can use it as the base for a temporary crown. Here's the case when it's restored. We ended up also crowning the adjacent teeth because the patient wanted to close the spaces between them. Let's look at a lower molar case. Simple lower molar. We went and placed the healing abutment, custom healing abutment on the day of surgery because of high ISQ values. And this is what this tissue looks like here on removal, first removal. And how can you say that you'll ever achieve these results with a stock healing abutment or having the lab guess about the emergence profile in the molar zone. I think it's impossible. And like I mentioned, you can scan this quite deep. There's no issue with scanning this. And that's what the case looks like from the lab aspect. Here's another case and an upper anterior. This is a Straumann implant next to an old veneer. Again, we go ahead and digitally scan the case. Again, no issue. We can scan quite nicely right into the emergence profile that we've established. Again, obeying that rule of adequate abutment height in order to ensure that we don't have compression against the bone, allowing as much tissue thickness around our implant head and maintaining that vitality around the area. So I don't want to have the implant crown right up against the bone. Another case, lower molar. Again, same day cervical abutment and scanning it. So you see a trend here. I think once you understand the philosophy behind this, you'll be able to replicate the results like this over and over and over for your patients. So I think when I see this, I think, I don't know about you, but I get excited to see these kinds of results, especially after my inserts are so seamless. There's no guesswork from the technician or the lab anymore. And now we have full control of that because we do all that work ourselves in office. But if you're not at that point yet, sending that extra information to the lab is going to give a lot of excellent results back, and you'll be happy. The patient's going to be happy as well. So this is on first disconnect. So you'll see a little bit of bleeding, which is perfectly normal. On crown insert day, that's what it will look like. Another case, here's a socket shield case and cervical. So the patient had split his upper premolar into two. I actually ended up taking the extracted tooth, grinding it using the Cometa Bio dentin grinder, and regrafting it in the gaps. So after I placed the implant, socket shields performed, I regrafted the gaps with the dentin, and we did a socket shield procedure, and did a seal of the area with the cervical abutment, and insert. Here's another case, upper anterior central implant, which I did GBR on a few months prior. We go ahead and do our implant placement. We ended up grafting again on the facial aspect. The patient was quite happy to go with an Essex in this case, so we didn't go ahead and do immediate loading of the implant. If the patient's fine with it, I have no issue with temporizing with an Essex retainer with a tooth on it. It's less headaches for you, worrying about patient compliance, especially if you don't know the patient that well. Closure. When we came back 3 months later, we started to develop the tissue. So we pick out the correct tab size for a central implant, start to create our emergence profile. And I think this is a very nice slide that illustrates the position of our implants and how we need to control that emergence profile. If you leave this up to the lab, there's going to be a lot of guesswork. So if your implant placement is centered, your emergence profile on the facial needs to be slightly concave. And the rationale is that you want to maintain the soft tissue. If your implant's too facial, you actually want to have that emergence profile on the facial to be concave. So you need to allow that concave area to allow for tissue creep in there to increase the soft tissue thickness. But if your implant placement is too palatal, you actually want to push out on the facial aspect, your implant profile, your implant crown profile, to compensate for it. So be aware where your implant placement is, because if you just take an impression and send it back to your lab, who may not understand this, and you go ahead and insert the crown, you may have recession issues and wonder why. So if you're able to customize the shape yourself, convey that information to the lab, your results are going to be much better. So the cervical abutment's complete. And this is a scan with the iMedit at our other practice. This is the crown on insert day. If I can, I prefer a custom abutment all the time, because I find that there are limitations with tie bases. A custom abutment, although it costs a little bit more, gives you much more control in terms of the tissue shape and also in terms of strength long-term between your implant crown and also the custom abutment. You're going to have much more surface area for bonding to. So a tie base, it's not my preference. You know, if you can do this with custom, it's better. And this is on the insert. So I think, you know, getting this kind of result for this case in working with the laboratory and yourself, you know, these are one of the most difficult cases you can do, is a central anterior single tooth. And with the help with this system, we're able to predictably achieve these kinds of results, assuming your surgery goes as planned as well. Here's the patient, very happy patient with the result. This patient was quite interesting, actually. Throughout all the surgery steps, when I was taking my pictures, she asked me to have some of the pictures sent to her because she was curious about the surgery. So the patient actually was very interested in seeing the pictures herself, and also in terms of her interest in surgery. So she was a really funny patient. This is another case with anterior socket shields on all 4 teeth here. So this is what the patient came in with. So she had very large post-core buildups that have broken or debonded several times. We posted this case online, and you know, clinicians were saying, why did you remove the teeth, and why not try and do crown lengthening and post-core buildups? You know, we have long discussions with patients about things all the time, and we tell them, you know, these are the choices and pros and cons, and they make the decision end of the day. So I didn't want to have total extraction therapy performed on 4 adjacent teeth. So if you're not familiar with partial extraction therapy, I suggest that you look into it, read on up on the literature, and attend a hands-on course as well. So we went ahead and performed removal of the crown portions and performed partial extraction therapy on all 4 segments. I ended up in this case placing my implants in the central positions. Although my preference is to go in the lateral positions, the bone was much better in the central positions in this case, and there were undercuts in the lateral I was not very happy with. So you'll still get an optimal result by joining and splinting these together in the end. So we went and placed, I think, 375 by 11.5 Newton GM implants. again, this case, the patient was coming out of town. I didn't have a long-term relationship with them. They were okay to wear an Essex appliance, so I did not immediately load the case. So we ended up grafting the area, placement of our implants. We performed grafting over top with collagen plugs, simple closure, and we returned 3 months later. So we start to perform shaping of our implant placements. Go ahead to scan body impressions of the area. And we ended up with a splinted bridge. So in this case, you have several choices, being 2 non-engaging abutments into the implants, or having an engaging implant connection in one and having a custom abutment in one. So for me, by doing so, we're ensuring that our case is going to fit passively, and also we're taking advantage of the hexing in the implant to ensure that we don't have extra stress on the screws only and potential loosening of the screw. So this is on the insert, a splinted prosthesis with partial extraction therapy and the cervical concept. We're almost at the end of our cases, and I'll answer all your questions at the end here. So here's a few cases that I don't have final restorations yet, unfortunately, due to the COVID situation. But you know, when we hopefully get back soon and resume the things we love to do, we'll have updates on these cases on our forum. So anterior bridge that had debonded. We went ahead and made a surgical guide made in office. So, you know, part of the digital workflow is some patients or some practices will have these sent out to other places. If you're interested in getting into these concepts and able to print them, it costs $5 in resin to make something like this in your office. So for me, it took, the longest thing was the extractions of the teeth. My implant placement took less than 5 minutes after. So we ended up placing our implants, custom cervical abutments, grafting the gaps. You'll notice here that we have quite a large gap, and that's because the original teeth had quite the recession on the one. So I'm allowing the tissue to actually creep up over time coronally, and by leaving that space, that allows the tissue to do so. Another case with socket shield anterior. Again, I don't have final restoration for it yet, but it's always a must to take CBCT on these cases to ensure what your implant trajectory is going to be like, and also to see what kind of root orientation that you're dealing with. So you cannot do these cases without CBCT. Go ahead and perform partial extraction therapy. Did a shield or a placement of our healing abutment. Another case, again, I'm waiting on. So all these patients, you know, are going to have extra integration time when we return to private practice, and I'll post the results at that point. So another case, central and adjacent lateral were affected. The lateral had a vertical fracture seen on the CBCT. We made a digital guide in office. Go ahead and place the implant. Perform a roll flap and custom cervical healing abutment. And patient walks out with the Essex appliance he had before. So we can, again, immediately load these cases. But you don't have to do that if you're unsure or you're not comfortable about the patient being compliant. So we're still waiting on this case for final result. And this was my last pre-COVID case. So believe it or not, like, you know, I don't know when we're going to see this one restored, but when we were doing this case at the time, I didn't think we would be in this situation. But, you know, here we are. So this one was a case of 2 central implants that I had placed. Again, in the lateral position, sometimes you have undercuts or the bone's deficient. You can go ahead and do a central placement of your implants, like the bridge case I showed you prior to. We'll touch quickly on a few other uses of the cervical system. You can use it to, again, measure spaces. You can use it as a semi-surgical guide. Keep in mind, it's going to give you mesial-distal positioning of your starting point of your implant placement. It's not a true surgical guide because it's not corresponding to your CBCT. So don't go and drill blindly to your full implant depths and widths without visually looking to see if you're out the bone or not. You can also use it as a diagnostic guide. So in the lower case, you simply do not have enough room for an implant placement while respecting the rules of being 1.5 millimeters away from each tooth. Like I mentioned, you can make custom temporary abutments, custom crowns. You can scan for custom crowns as well, or modify the temporaries. You can make also modify the temporary healing abutments to be preparations that you can insert a temporary bridge on as well if you wish. So a lot of colleagues are using this throughout the world, and you know, this is not meant to be a sales pitch, but for me, seeing something like this, it kind of clicked into place what I was looking for and achieving the results that I want. So it's important to understand the philosophy of why the system works. And for me, you know, the investment is in itself paid off itself many times over because of the results I'm achieving. So I'd invite everybody to check out our website, and you can subscribe on there to see future courses and events. Hopefully we'll resume those soon. If you're not on Facebook, join our Facebook group, and we have a talk actually at 2 o'clock with Dr. Zastro that you're welcome to check out. And thanks everybody for your time.
Fantastic, Mark. Thank you so much. It was wonderful. Very, very interesting. Appreciate every minute. So let's go to the questions. So can you read?
I'll start with the bottom here. I can read them here.
Okay.
So Daniel is asking, hey Daniel, in partial extraction therapy, when do you remove the buccal portion of the root? And the answer is we don't remove the root at all. It actually stays in place, and that's the aspect or reasoning behind this therapy, is to leave it in place and allow for preservation of the bone and tissue contour, so it never gets removed. Okay. And how much are you charging for a custom abutment? For me, because I perform the surgery and the prosthetic phase myself, you can charge what you want. For us, we charge a flat fee, but I don't charge differently whether I'm doing the cervical case or not. For me, I do it because I'm setting myself apart, and I see value in doing it. I don't want to have issues with an implant crown having issues down the road, and the patient's going to return to you. You're married to these patients. So remember that. So if you're performing something and you believe in the value you're providing to the patient, it shouldn't be about the cost of the healing abutment. For us, we charge an all-in fee. So that includes the extraction, implant placement, grafting, et cetera, We do not break it down by custom abutment or not. So the patient, they don't need to see a listing of every itemized aspect of treatment. They just know that they're going to get the tooth, and this is how much it's going to cost. I think that's easier to understand for the patient. Mirko asked if I have a library for most of softwares. I'm not sure what you mean by that, but I mean, the cases we were showing were scanned either in iMedit or in the Trios digital scanner. At that point, it's an STL file, that's a data file, which is sent to the laboratory. They can do the design in any software of their choosing. Common ones include ExoCAD, or it can be designed in 3Shape software, and that file then will go to the mill. So the file from the scanner, it's a standardized file. Do you have follow-up of the 2-implant, 2-cantilever prosthesis? No, that wasn't my case, but this was a colleague's case where he says, I think I placed my implant deep enough. This is what I got back from the lab. Can you tell me how to fix this? So, number one, the lab doesn't understand the principles behind what they're trying to achieve, right? And number two, if the dentist doesn't understand it, then you have the blind leading the blind, and that's a big problem.
Another question here, Mark, is there any adverse effect of placing polished collar of abutment 2 millimeter into the bone by Parrish?
Where was that?
Oh,
Is there? Well, yeah, the polished collar. I mean, you cannot place the polished collar subcrestal. The polished collar is meant to be at tissue level. So if it's a tissue level implant and you go place it subcrestal, you will get bone dieback because there's no adherence of that portion of titanium around your bone. So you need to respect your implant design and why you're using it. And I know there's a question here about why I'm using Neodent. I've used Iosin implants, Neodent, Straumann. I look for certain features and implant designs that I work with. For example, I want an implant that is platform switched. I want an implant that's reasonable in cost. I want an implant, that's going to have good primary stability, good thread design on it. So by no means am I saying this is the one implant you need to use for these cases. You can do these cases with many implant companies, but also you need to be able to see that implant company has, for example, a software library for their implants.
Yes. We have a question from Ioannis Vergoulis. Mark, do you also see an improvement of soft tissue thickness for regular and immediate cases by using cervical healers?
Yeah, I mean, for sure, especially around immediate placements. What I have tended to do is this: place either a stock abutment first, let the tissue creep in, fill the gap of that extraction socket. Now we have that extra tissue to gain. And at second stage, move that tissue again with a cervical abutment. So for me, sometimes doing that is a bit better than jumping to using a cervical abutment in one stage if I have deficiencies in tissue. Because sometimes you'll want that tissue to move coronally, for example, right? Or if you're worried about stability of your implant, perhaps burying it and returning to use that cervical abutment later is a great advantage. But in terms of thickness, you saw like the stock abutment case that patient came with, and I was like, this kind of looks like shit. I think I can do better, right?
Yeah.
And I pulled up pictures on the screen to the patient, and I said, do you mind? I'm going to show you a picture or two. I said, do you mind they have bleeding in the picture? She said, no, I don't mind. I said, do you see your implant you had done in front? I said, yes. Do you see the stock healing abutment shape? Yes. I said, do you see the shape of this tissue on another case that I'm showing you? I said, do you see how this is sculpted to look like a natural tooth would look like? She said, yes, I understand it. I said, well, do you mind if I do this extra for you? I'm not charging you extra for it, but it's going to provide you a better result. Not one patient has ever declined that.
Yeah, let's hope that it all becomes a standard of care someday.
Yeah, I think for us, it's the dentist. We want to finish things quick. but then it's going to come back and bite you in the butt later, right?
Mhm.
So
At some point it does. Yep.
at some point, right?
So can we use a stock healing abutment and use the cervical stent to improve the contour? Tanzine Raiz.
Can you repeat it again?
Can we use a stock healing abutment and use the cervical stent to improve the contour?
This is the problem, though. The stock abutments, okay, you're going to the height of those stock abutments is going to be a limiting factor, right? Because most often I'm cutting and shaping things outside the mouth. I cannot do that on a stock abutment. So if it's a peak abutment, I can cut it, or if it's too tall, I can cut it down. If you use a stock abutment, you're going to also have issue with orientation, right? How are you going to design that relative to your cervical mold? It doesn't work like that.
No. Mark, what you can do is you can scroll down a little bit further and you can read them yourself, actually, because it's going to make life easier for you.
Okay. Do you have any video on usage of cervical? Where do you buy it? Why not use a wide diameter healing abutment? So, you can use a wide diameter healing abutment without issue. In some cases, that will work just fine. Keep in mind the cases I showed you, a wide diameter healing abutment still does not have the right shape for a molar, for example. Okay, so you cannot get shapes that are shaped like a molar adequately. Also, you'll have to have such a wide range of parts on hand in order to accommodate all those areas. So you need to have how many shapes on hand in order to do that? I think a lot. So for me, having the ability to control this chair side is a lot easier. In terms of videos on usage of cervical, you can check out our website for purchase under the online store, so cdnimplants.com, if you're wanting to check out the product as well. The name of, I think that's about it, right?
Yep, I think we're good.
Okay.
Mark, I want to thank you so much for your time. We really appreciate it. We appreciate everything that you're doing with the system. And it was nice meeting you for the first time too. I'm looking forward to more and more of this in the future.
Okay.
Thank you so much.
Okay, bye.
Thank you. Take care. Bye-bye.
Bye.
Ladies and gentlemen, I'd just like to inform you that next week, Thursday, I will also be doing a lecture, and I will be going through the A to Z of the product. So I look forward to seeing you all there. I'm going to go into great detail on how the product is used. So Thursday, 7 o'clock Cyprus time, Greece, Athens, EST, I think it is. So I look forward to seeing you all then. Take care. Bye-bye. Have a great weekend.